The coagulation cascade, intrinsic, extrinsic, and common pathways explained. Hemostasis is one of the most elegant and precisely regulated systems in the human body. When a blood vessel is injured, a cascade of serine proteases activates in sequence, each amplifying the signal, culminating in a fibrin clot that seals the breach. Understanding this cascade is essential not only for board exams, but for interpreting coagulation labs, managing bleeding patients, and understanding anticoagulant drugs. Today we go deep on the coagulation cascade, every factor, every pathway, every clinical connection. The coagulation cascade has two initiation pathways that converge on a common pathway. The extrinsic pathway is the primary physiologic route. It is fast and activated by tissue injury. The intrinsic pathway amplifies and sustains coagulation. Both feed into the common pathway, which produces thrombin and fibrin. The extrinsic pathway begins when vascular injury exposes tissue factor, also called factor III or thromboplastin, on subendothelial cells. Tissue factor binds circulating factor VII, activating it to factor VIIa. This tissue factor VIIa complex, in the presence of calcium and phospholipid membrane surfaces, activates factor X to Xa. Factor VIIa also activates factor IX, linking the extrinsic pathway to the intrinsic pathway. The extrinsic pathway is measured in the lab by the prothrombin time, PT, and its normalized version, the INR. Warfarin prolongs the PT by blocking vitamin K-dependent factors 2, 7, 9, and X, but factor VII has the shortest half-life, so PT is most sensitive to warfarin. The intrinsic pathway, also called the contact activation pathway, begins with factor XII being activated by contact with a negatively charged surface such as exposed collagen or artificial surfaces. Factor XIIa activates factor XI to XIa. Factor XIa activates factor IX to IXA. Factor IX combines with its cofactor, factor VIIIa, calcium, and phospholipid membranes to form the tenase complex, which powerfully activates factor X. The intrinsic pathway is measured in the lab by the activated partial thromboplastin time, aPTT. Heparin prolongs the aPTT by activating antithrombin 3, which inhibits thrombin and factor X. Hemophilia A is a deficiency of factor VIII. Hemophilia B is a deficiency of factor IX. Both prolong the aPTT with a normal PT.
The common pathway begins where both the intrinsic and extrinsic pathways converge, at factor X activation. Factor Xa combines with its cofactor, factor Va, calcium, and phospholipid to form the prothrombinase complex. This complex cleaves prothrombin, factor II, into thrombin, factor IIa. Thrombin is the central enzyme of coagulation. It is a serine protease with multiple critical functions. It cleaves fibrinogen into fibrin monomers, activates factor XIIIa, which cross-links fibrin into a stable mesh, activates factors V and VIII in a positive feedback loop, massively amplifying clot formation, activates platelets, and activates protein C, which eventually limits coagulation through negative feedback. Fibrinogen, factor I, is cleaved by thrombin into fibrin monomers that polymerize spontaneously. Factor XIIIa, also activated by thrombin, cross-links fibrin polymers through covalent isopeptide bonds, creating the mechanically stable clot. Coagulation is tightly regulated by natural anticoagulants. Antithrombin 3 inhibits thrombin and factor Xa. Heparin dramatically accelerates this inhibition 1,000-fold. Protein C, activated by thrombin bound to thrombomodulin on endothelium, with its cofactor protein S, degrades factors Va and VIIa. Deficiency of protein C or S causes hypercoagulable states. Tissue factor pathway inhibitor, TFPI, limits the extrinsic pathway after initial activation. Fibrinolysis removes the clot once healing occurs. Plasminogen is converted to plasmin by tissue plasminogen activator, TPA. Plasmin degrades fibrin into D-dimers, which are measured in the lab to detect thrombosis. Elevated D-dimer is sensitive but not specific. It rises in PE, DVT, DIC, surgery, infection, and cancer. Key clinical correlations: factor deficiencies and their coag tests. PT prolonged in extrinsic pathway defects, factors 7, 10, V, 2, fibrinogen, and warfarin. aPTT prolonged in intrinsic pathway defects, factors 12, 11, 9, 8, 10, 5, 2, and heparin. Both prolonged in common pathway defects or DIC. Direct oral anticoagulants, DOACs, target factor XA, rivaroxaban, apixaban, edoxaban, or thrombin, dabigatran, with minimal effect on standard coag tests. Understanding the cascade is the key to rational anticoagulation management. Subscribe to Medical Sciences Unfolded for daily deep dives into the science of medicine.